Hello, everyone, and welcome to the third episode of the RLI Power Hour webinar series. Tonight's topic is achieving alignment in the healthcare system. My name is Jennifer Pendo, and I'm the program manager with Radiology Leadership. And before we get started, I would like to review a few logistical items so you know how to participate in today's event. Here's an example of the GoToWebinar control panel. You'll see something that looks like this in the upper right corner of your computer screen. When you join today's webinar, you selected to join either by phone call or computer audio. And if you've used your phone, please be sure to enter your audio PIN number, which is found in the audio pane section of the control panel. If for any reason you'd like to change your selection, you can do so by accessing your audio pane section. There will be a Q&A session at the end of today's webinar. You'll have the option to submit text questions to Dr. Breslau and Dr. Meltzer by typing your questions into the questions pane of the control panel. You may send your questions at any time. The moderators will collect these and address them at the end. Or if you prefer to ask your question verbally, you may raise your hand by clicking on the hand raising icon on the grab tab to the top left of the control panel there. And when you are called on, we'll unmute your line and ask you to ask your question. So now I'd like to go ahead and introduce tonight's program organizers and co-chairs of the RLI Power Hour webinar series. I have Drs. Jeff Rubin and Jennifer Nathan, who are serving as our moderators for this evening.
Thank you very much, Jen. Hi, this is Jeff Rubin, and so delighted that you're all with us tonight to discuss a really important topic, which is achieving alignment between radiology with the health systems in which we operate. And I can't imagine that anyone on the call doesn't recognize the importance of this topic, the increasing interdependency that we find between our departments populated by physicians principally and the interpreters of the images, and our systems where increasingly the personnel and the equipment that are critical to the acquisition of our images resides, as well as a key connector to our patients and to our referring physicians. And for tonight's discussion, I can't imagine having two better, more expert and more experienced presenters than Dr. Jonathan Breslau and Dr. Carolyn Meltzer. Dr. Breslau chairs the imaging department at Sutter Medical Group in Sacramento, California. He has been a member of the Sutter what was originally Radiology Associates of Sacramento, one of the longest standing radiology practices in the country, and was president of that group. He was a member for 35 years and helped to usher in the transition from the group being an independent private practice to becoming a part of Sutter Medical Group, which is a large system through Northern California. And that experience is one that he and I explore as a part of a podcast in the Taking the Lead series, which I hope that everybody is aware of and hopefully has had a chance to hear that and to hear a bit of Dr. Breslau's journey. Dr. Breslau now is leading the diagnostic imaging standards on a system-wide basis for Sutter Health, and so brings tremendous perspective from a community care perspective on alignment with the health system in Northern California. Dr. Meltzer is a world-renowned neuroradiologist and nuclear medicine physician who has done tremendous work over the years in the development of novel methods for studying brain structure function, relationships and the normal and aging brain in depression, Alzheimer's disease. To speak about all of her connections and accolades in the research world would probably use up our entire time. So let me just turn my attention to highlighting her very important role as the chair of radiology and the William P. Timmy Professor at Emory University, where she also serves as Associate Dean for Research. But in her role as head of radiology, she has seen tremendous growth in a system that is rapidly expanding throughout the Atlanta metropolitan area, bringing academic practice into the community and working to share the spectrum of healthcare delivery across community sites all the way to the main university. So without further ado, let me express our appreciation to Dr. Breslau and to Dr. Meltzer for joining us today, and perhaps just also very briefly mentioning my co-moderator, Jen Nathan from Johns Hopkins, who will be taking on the tasks of moderating today's session. Without further ado, Jonathan Breslau.
Thank you, Jeff. Thanks to the RLI. And I definitely would have to say that appearing as a co-presenter with Dr. Meltzer is one of the highlights of my career. Thank you for the invite. So I want to talk about alignment with health systems, and I'm kind of going to present as three concentric circles, really. First, focusing on the general healthcare environment in the United States, then narrowing it down to health systems, and then finally spending time about how imaging departments can align with what health systems are trying to do. The first graphic slide I have here is talking about how what has been historically a successful financial structure for getting paid for healthcare is starting to decline in terms of its viability. We talk all the time about a private/government cross subsidy, and that's really under threat over time going forward. Also, because of projected growth in Medicare and Medicaid expenditures, the government payer that's growing as a sector of all payments is also under threat, and healthcare entitlements are nearly certain to be cut, so that at the same time government-funded proportion of healthcare grows, the pressure to rein in those same sources is going to increase. And the graphic here shows projected growth if no changes in general policy take place between now and out to 2026. Inside of that government pay, well, actually, in Medicare specifically, there's also a very large challenge in terms of how the costs are expected to go up. Part B, which is the darker gray, and Part A, which is the lighter gray. And you can see the biggest percent increase is in the Part B, which is physician services. But both are under great threat, the hospital and the physician services. And really, there's going to be requirement of models emphasizing provider performance on patient safety, clinical effectiveness, clear coordination, and cost efficiency. And then a third thing that's a problem is historically, a lot of health systems, including ours, have been pretty well matched up across the table with the payers, and the negotiations have been kind of eye to eye or equal to equal. But what's really happening now is combinations more on the payer side and larger vertical integration, so that the organizations that used to be matched up nicely are now across the table much bigger. And you see the biggest one there is really is CVS Aetna, which is going to be going through. And then most of the other ones are some way involved in payment or will be involved in payment, whereas the largest health systems really don't match up very well. So what health systems are seeing is no expectation of getting paid more, undermining the public-private cross-subsidy, and competition from larger vertically integrated enterprises. And they're really going to need to move away from the primary goal of filling beds at high cost and high charge, and ultimately need to be engaged directly with the patient at an affordable premium. So what are they trying to do? Well, three basic things, and then the goals below. First of all, cost efficiencies, which includes things like, oh, and I just want to say, as you're listening to this, think the idea of my presentation is to be thinking of ways that imaging can address these. Anyway, cost efficiencies, variation reduction, standard purchasing, efficient use of fixed clinical capacity, and under resource use, shifting site of care to lower cost, consolidation of services to higher volume sites. And then under better patient management, things like eliminating duplication, reducing over-testing, and providing the right care at the right time. At the health system level, what they're really trying to do, and it goes back to the bottom of my previous slide, they need to manage risk and be able to take in a fixed amount of money and know that they can survive on it. And as imaging departments, we need to figure out how we can match up with those goals. So again, aligning with the system strategy, which the first task is to understand what the system strategy actually is, and to realize that there are benefits from standardizing across the entire system. Focusing on eliminating low-value care, and imaging is ripe for that kind of thing. And work to support predictable imaging spend with consistent recommendations, so that the health system knows what the cost of imaging is going to be for them. That's really predictable. An important area is variation reduction, which is really part of the cost of care. There's a lot of work in our field on this area. Certainly in the JACR, you see a lot of publications about evidence-based guidelines for recommendations. And what will really juice that and push us along faster this year is the requirement to implement computer decision support, both to install the platform and also to bring in appropriate use criteria, such as what's available through the ACR. That will really move the process forward, but it requires standardization and a very broad look across the footprint of the health system. Also, it requires alignment with specialists, because you have to have agreement on what guidelines you're going to follow and how you're going to structure the care. For appropriate use of clinical resources, you're seeing ways that imaging can help support shifting care to low-cost sites. More and more doing interventional radiology outpatient is one, whether it's independent clinics that are set up or whether it's joint venture or wholly owned by the hospital, but to get it outside of the hospital. Consolidation of services where appropriate, especially to be able to get subspecialists access to large volume of the appropriate examinations, and to really manage a large distributed imaging platform. And then one example is stroke center, where you really need to have consolidation of resources at a smaller number of sites. And then, of course, we're probably already engaged in this, but at a even bigger level, at a very large scale, standardized purchasing in terms of agreeing on sequencing of purchases of large equipment purchases, such as MRIs and CTs and PET CTs and so on. But then also at a smaller level to standardize purchasing of things like catheters. Imaging certainly has a role in better patient management in terms of eliminating duplication. There's some very good work coming out of the Neiman Policy Institute on that. Reducing over-testing, right care at the right time. And those are all related to CDS and utilization management, but at the benefit to a health system really is when it can be performed at scale. At the same time that you're trying to do that, there's a large benefit to be realized in being able to engage at the top level of the health system. In general, that's how the EHR has been developed and deployed and how it's managed. And imaging enterprise will have a much larger impact if you're engaging at that same top level, where you can deploy enhancements to Epic, for example, across a health system using the high-level IS people that are centralized. This is an example of something we did that's using the scope of the health system for a patient experience, showing how the broad scope improves access to resources of the whole health system. What we wanted to do was narrow the time across our entire enterprise of women who have mammograms that are BI-RADS 4 or 5 to the time they actually can get an appointment for biopsy. We need to coordinate across a large geography. All of imaging at Sutter is about 3 million exams a year over a large part of Northern California. And in looking through some of the obstacles of why people couldn't get in as quickly as we wanted to, we found that there were a bunch of things that weren't standardized and weren't predictable, such as the patients who were excluded because of anticoagulation, that it was kind of randomized and even varied day to day based on what doctor was working there. And we came up with a standardized anticoagulation indications. But then also we found that certain payers required pre-authorization for biopsy. And when you think about that, that makes no sense at all. 100% of BI-RADS 4 or 5 are supposed to have a biopsy. It's not a judgment call once you get to that point. And we went to payers one at a time where we found these obstacles, and we were really speaking on behalf of Sutter Health as opposed to a small imaging center where they really didn't care what we thought. So that we were able to make changes there. And then finally, we were able to make changes in in some of the EHR information where it had questions when patients were signing up, when it had questions where patients were checking out from their diagnostic mammogram that would prompt, when do you want the biopsy and how can we do it? And so that all the different office personnel would see it as they were checking the patient out. And again, the only way for us easily to change Epic was at the system level. And it allows us to really market across the whole health system in terms of patient experience. Some additional examples are, and this is things that we've deployed across the health system, incidental and just in the last 2 months, we took in the adrenal and the pituitary that are now engaged with, pituitary with neurosurgery and with endocrinology as well as imaging that are standards across the entire health system. So we know here's how these things are going to get worked up, or more appropriately, how they're not going to get worked up. Contrast screening policy, so we stopped checking GFR for gadolinium and so on. And then also the capital planning is now being done at the system level. So, and all of the other entities such as hospital CEOs are looking to us to get input and support and prioritization for what type of projects need to happen. And at the senior most part of the health system, at the C-suite level, it's very reassuring to them that there's one look at all of the capital spend on imaging. The most important starting point, even though I'm ending, this is my starting point, is to set up a system imaging committee that really matches well to the footprint of the entire health system and start making up processes for making system-wide decisions, developing a charter and all that kind of thing. And I've listed a couple of things that I don't need to go into, but it's very important, even if you don't care about alignment, if you only care about just imaging's place in the food chain, it's very important. Because I think doing nothing really helps move us towards ancillary status where imaging is its own little island in every single hospital and facility, perhaps next to the laboratory and the laundry or something. And I think this is something that really lifts the imaging enterprise out of any possible relegation to ancillary status. And the final point I want to add is the political challenge needs to be respected and taken very carefully. And I think the first thing as you're trying to roll out system level coordination is fear. The first response is fear, and what are you trying to do? And we had to be very deliberate about, well, here we're just talking about standards and so on. And I think if you don't, you're going to spend all your time fighting and none of your time aligning. So to summarize, understand the big challenges that your health systems are facing, that they're trying to change stuff in a very big way that in some ways is much more scary than the forces facing us as imaging departments. And as I talked about the committee matching the scope to the system footprint, and really to be thinking constantly, how can imaging facilitate the systems management of risk?
Okay, thank you, Jonathan, for that excellent foundation. I'm delighted to be here with our moderators, Dr. Rubin and Nathan, and having this talk with Dr. Breslau. So, we really bring very complementary perspectives. That was a wonderful foundation of some of the challenges. I'm going to talk from the perspective of an academic center that's undergone a lot of change and market consolidation over the past decade. But a lot of the issues are the same, and this is a journey and filled with a lot of change. So I have this little sort of visual here that reminds me that while I may represent radiology's priorities as chair of the radiology department, the health system priorities are growing bigger, and generally it's really a balanced, gentle tug of war. And my position, as many chairs and leaders of radiology departments and practices have found over the last several years, my role is really much more of showing how radiology brings value to the system rather than sort of saying, no, we need this because that belongs to radiology. So it's a very, very much of a different way of looking at things than a number of years ago. And you might also think as systems get bigger, that the health system has priorities, and each site, especially as you have new sites come on with hospital consolidation, market consolidation. We have recently gone from 7 hospitals to 9 hospitals in our system and growing. And each hospital, each site can have a different flavor to it. And while there needs to be alignment with the overall health system, that is a process, and that is really an issue of change management, making sure we don't homogenize everything, but benefit from standardization of best practices. So when you think about radiology, we really touch every service line in a system. Depending on how your imaging services are delivered and what falls under imaging, it could be that 90% of the patients who come into the system are touched by radiology. And as Dr. Breslau mentioned, sometimes we get lumped into thinking about ancillary services. And what we have tried to emphasize is that we are core, our essential services that serve the system. Or as one of my division directors used to say, when radiology sneezes, the hospital catches a cold. So we are essential to the success of the system and to seeing it run well as the innovations we bring that really distinguish us from a commodity to really an essential and distinct service line of benefit to all. So it is critical that physicians show accountability throughout the system. And I think sometimes we've relegated that or delegated that role and said, oh, it is for the staff to worry about how long the patients wait in waiting rooms and what their experience is like, and we don't control a lot of those things. As you know, physician leadership has grown enormously. That's part of this program and others. And we've moved much more toward physician administrator dyads, and then ensuring that the physician voice is heard, but there is also the accountability that goes along with it to make sure we are accountable for system goals and for department goals. A lot of places are moving to make sure that physicians and administrators have some similar incentives and some shared risk sometimes. So money that comes back to my department to fund programs is related to key metrics of the system that we can influence. Some of them are more specific to radiology, but some of them are those that we need to support, but are system-wide and cut across every service. And prioritizing the patient experience and making sure that, of course, that is a system goal, but we make sure that the patients have the best experience with their radiology care. And I'd also extend that to our referring clinicians. Having an engaged workforce in our departments, and that includes transporters, nurses, technologists, radiologists, administrators. We have very intentionally flattened the hierarchy a bit, so there aren't as many silos within the department, and there is much more of a feeling and culture that we're all part of an interdisciplinary team. Anybody can stop the line if there's a concern about quality or care delivery, and that is critical to folks speaking up, being satisfied, feeling like their voices are valued. So leadership in the context of systemness, and this is a term that is now taken off a little bit, it is that that concept that systems are complex, matrixed, but that there is value gained from moving in the same direction and aligning forces. So leading in the context of systemness is very different from focusing on leading a practice. It is not command and control. And when I seek to bring new leaders onto my department, a red flag for me is when a candidate says, I want to know exactly would be in my control if I'm in this leadership position. Where are the four walls of my box? This new kind of successful leadership in the context of systemness is much more matrixed. It is a lot of influence and networking and a lot of dual and multiple reporting, which can be uncomfortable for those who really want to know, what do I control? And the parts that we influence have substantially enlarged in successful systems where radiology has taken a leadership or system approach. So I think of this as requiring bifocal vision. So being able to keep your eye on the ball in terms of operational detail, but have the big picture, think outside of just the department, think of partners, think of the system as a whole. How can we perform better so that the system benefits overall? It takes a lot of time building trusted networks and negotiation that is not the sort of classic, you want this, I want that, and let's split the difference. It's much more about thinking outside the box, thinking of new solutions, thinking of new approaches and new ways to partner to further the system and the system's goals. Strategic partnerships are critical. I think when I first became chair, the hospital-based services were seen as, we need them, but they're really to serve surgery and medicine and all the other practices. What we have found over the years is that when we have a new hospital site or a new physician site, multi-practice site, that the first thing our colleagues say is, gee, we have to make sure we have the infrastructure for radiology because we can't live without that. So they tend to think of us first rather than as an afterthought. And that really takes making sure your partners see your value as well. And clearly influencing without having formal roles. So we've talked about this in other RLI sessions, formal and informal leadership, regardless of your title or whether you have one, exerting influence and positive influence outside of the scope of that title is critical. So I'm going to share, this is an article there's an article that's going to come out in JACR, just revised the proofs today, about an investment we made in Emory Radiology a decade ago. And we now have nearly 10 years of experience with this. We think of really a knowledge workforce. What is the most important thing? That is investing in the talent. So we implemented and have continuously refined a department-based leadership academy, which is quite rigorous. It's a 9-month intensive program that is purposely interprofessional. So the RLA fellows, not to be confused with RLI, the RLA fellows are both faculty and staff, early leaders, early to mid-career leaders, or those we feel have great talent and wish to be groomed for their first leadership role. And there is a real process to the criteria and selection of these folks. We have made sure that our investment in the future leadership of the department is, increasingly diverse, because we know that makes us stronger when we work in diverse teams. And it has multiple components where we teach leadership skills such as negotiation and crucial conversations, communication skills, HR skills, but there's also embedded team projects that are really roll up your sleeves projects, focused on innovating in an area of care delivery or quality in the department. And those teams, again, are faculty and staff together. And they're often a research faculty member, clinical faculty member, staff members from various parts of our institution. And we really also focus on some of the broad strategic goals and skill sets. Fundamental to all of that is self-awareness. And we also focus a lot on teaching folks skills for self-reflection, reassessing how they're doing, thinking of leadership as a lifelong journey. And this has been a very successful program. We've graduated now over 100 colleagues who are throughout our leadership structure within the department. Another program, which is also about investing in our people, and this is more around how do we tell if we're all rowing in the same direction? We have to have some conversations about that. We can't just assume everybody has the same idea of what's important. Our department has more than 1,000 employees, faculty, staff, and trainees, approaching now 1,100. That is a lot of people to just sort of gather in a room and say, want to make sure everybody understands that, how we treat the patients is important, that professionalism is important. So we have established a program, it's been going on also for about a decade, where everybody who joins the department goes through, within the first 6 months, what was initially a 2-day session, now is a 1-day session of the Service Excellence Institute, where we talk about empowerment of frontline folks. We talk about safety, courtesy, how we deliver care, the professionalism, how we engage each other, how we treat each other with respect, how anyone can stop the line, how delivering care efficiently is a goal, and that innovation in how we deliver care, as long as it's controlled and in pilots that are reevaluated, is also really important. So that has also been very successful. As our department, our systems get larger, there certainly is the tendency to feel, gee, I'm just a cog in a wheel. Am I really empowered? So making sure people know what they're empowered to do, and then rewarding that. So here's a little joke about someone's calling themselves a customer, says they want service. So we certainly go over how to approach our patients, and how to, and also engage patient and family advisors that help us to think from the perspective of a patient. But one thing that has really helped us to reinforce our service excellence training is to celebrate when a colleague goes above and beyond. It could be for a patient, it could be for a member of the team, it can be anything that brings those standards that we value to light. And these are folks who are nominated by peers, by team members who noticed what they did, and it really reinforces this support and celebrating of each other. And then we embarrass them. We catch them in the hallway and make them have a sign that says, I was caught in the act of service excellence. And it becomes mild embarrassment, but also a badge of honor. So systems, while market consolidation has been going on for a long time, it's been only in the last few years that really systems have shown significant cost savings from consolidation. And we usually think, gee, that should be obvious early, but it can be very difficult merging cultures across sites, and really aligning priorities. So cost savings is important, but it takes a while to realize, and it's important to try to get a handle on what those savings are. We went through a process a number of years ago called the Value Acceleration Program that, I must say, accelerated the value of radiology across the system by having it be acknowledged the power that we had in radiology to work across our system and lead in things like contrast contracts and service contracts for our scanners, and to have that power of a large system, as Dr. Breslau mentioned earlier, to result in true value. Looking at how our equipment was distributed, talked about investing in people, also looking at the hierarchy and being very intentional again about flattening that hierarchy, taking out lines of leadership and having empowered teams work at multiple levels. It saved cost, it saved, and it also helped with engagement and also working on our revenue cycle. The other thing are really metrics, and I find this sometimes to be a struggle to get real-time metrics, to get accurate metrics, to get the same kind of metrics across our sites, but really being able to show, gee, this is a system goal. A lot of times a system goal is length of stay. It's sometimes hard to show radiology specific role in decreasing length of stay. So what is a subset, a contributor to length of stay? How do we measure that? And how do we show moving the needle? And then trying to show what that impact is, not just for radiology, but for the system. So whatever those metrics are. And we instituted emergency radiology a number of years ago, and it is still touted by our system leaders as, a gift that radiology gave to the whole system, because it was seen as having such demonstrable added value. And this was hard to get support for putting this in place. We needed additional support to hire more radiologists, have them work 24/7. But the turnaround times for exams through all of our EDs dropped enormously, and had stayed there for, pretty much as a key deliverable. The communication with emergency medicine, getting patients through the ED has been a huge win for us. So just in summarizing, the alignment with the hospital really requires some adaptability, requires having both that organizational metrics and operational metrics, having a good handle on that, but thinking about adapting, thinking about showing that value to the system, about looking at the system goals and how radiology translates into moving those goals, that bifocal vision, being proactive on innovating on new services, on patient care issues, on access. And there is a little bit of the loss of autonomy. We, as a department, sort of, we determine what we want to do. There really isn't that sense anymore of the autonomous radiology department, or at least one that is going to be successful in the long run, but to really think about having skin in the bigger game and having a larger sphere of influence.
Okay, well, thank you, Doctors Breslau and Meltzer, for your expertise on such an important topic and for educating us on how to navigate through and overcome obstacles when aligning with the healthcare system. So at this point, we're going to open up the floor to our participants for some questions. As Jen Pendo had mentioned, you have two different options. You can either type a question in to be answered, or you can raise your hand and we'll unmute you so you can ask your question. To go ahead and get the conversation started, I do have one question for Dr. Meltzer.
Yes.
So you were talking about systemness and I guess specifically pertaining to radiology. How do you balance systemness, what the system is doing, with what is best for radiology? And when these are discordant, how do we as radiologists work with the system to achieve our goals?
Mm-hmm. Yeah, so I've tried to be clear about that when that comes up in a leadership meeting at the system level. I'll say, gee, I can see how we can help with that, but this will result in, a difficulty in radiology in how we do something, or will put a burden on our radiologists. So trying to make sure they know that I'm focused on doing what's best for the system, but that I may have an obstacle and we don't want to make life more difficult for radiologists. We don't want to have an added click or something that makes us less efficient or would be a hit. So something that starts a conversation of how can we align but mitigate a barrier or risk or a difficulty within the department.
Mm-hmm.
So it's wearing both hats at the same time and coming to trying to come to a win-win solution.
Mm-hmm. I have another question for Dr. Breslau. So you had mentioned to better manage patients, some of the things that we could do would be to reduce over-testing and unnecessary exams. Do you have any suggestions for how we could accomplish that? Having a better relationship with referrers, or is there any other ideas that you have how we could cut that back?
Yes, and it's a great question. It's something that they are looking to us to help work on. Well, first of all, as I mentioned, this year the CDS platform will move us down the field in that area, and I hope it's also an opportunity for kind of a cultural change, that there's more discussion across a large terrain of healthcare of what things we want to work on to improve. The CDS platform will provide us with data on providers and indications, and each system may be able to go and look what are some of the high value areas to target where we believe there's, the way that the CDS reports it with red lights or red, yellow, or green, where there's a lot of kind of overuse and bad indications for exams, and then you can sit down and have a discussion about it. So there's technology, there's more kind of boots on the ground, if you will, and then also facilitating, and I think this, in some of the things where I mentioned, like incidentalomas and standardized recommendations, that the radiologists are also incentivized to follow along with what are evidence-based guidelines. We implemented, the TIRADS reporting, for example, rather quickly, and we've been hearing a lot of very positive things. And the old reports where it used to say 1.5 centimeter thyroid nodule and then the signature, that's a thing of the past. So I think, and tied to that is also technology that can help support the radiologist at a case-by-case basis, so that when they're talking about something that's a standard recommendation, that pops up in the voice recognition system, and to be able to make it easy for them. I think if you're doing things to try to change radiologist behavior, anything that makes it a memorization exercise will be less successful than using the technology to support that. And that, for example, would be a good use of AI application.
Perfect. Well, looks like we do have a question. Oh, I'm sorry, Jeff?
No, that's great. I just wanted to point out that Ian Weissman has a question, and I've just unmuted him.
You muted him. Okay, perfect.
Thanks very much, Carolyn and Jonathan. Thanks. I have a question for both of you, Carolyn and Jonathan. Let's say that a new C-suite executive starts at your institution. They don't know much about radiology, and it's early on in the negotiations. You're trying to build a relationship for future negotiations, and you'd like to demonstrate to this person who doesn't know a lot about radiology how radiology brings value to the system, just to start to gain their trust. What are some of the things that you think really is high impact, a way to kind of get them on board, and a way to kind of build relationships and move forward? What are some of the strategies you both have used? Thanks.
Great. Carolyn, you want to start? I'm happy to contribute.
Sure. Yeah. Yeah, that's an important scenario. Thanks for bringing that up. And it's probably a lot of us have had that experience where someone comes on, they may think that radiology is a commodity, just a service. I think establishing a trusted relationship is critical. So seeking out that new individual, welcoming them, and talking with them about what radiology, some of exciting initiatives that radiology has done for the system, and seeing what his or her ideas are in their new role and how you can partner. It does help if you have metrics of success and can point to things you've done for the system that have had real ROI in terms of dollars or other value or innovation. But I think it's also being able to tell those stories and to be a colleague leader with that person.
Good. Yeah, and I would like to echo some of that, and it's a good question. And hi, Ian. The basis for the answer really is going back to, number one, understanding what that person's worried about and what are the pressures that the health system is under. And they're really looking at how do they create value beyond just pricing power, which is diminishing for them. So how can we work on cost, resource use, and patient management? We it's pretty much everything we've talked about, but I think you go to those basic ideas about standardized cost of workups, that standardized recommendations, so you're not going to be going on various kinds of goose chases. They could actually save a lot of money in CapEx in terms of managing it at a top level. And then also something which we didn't really mention, which is really clinical coordination, how imaging supports the other service lines, cardiovascular and neuro and oncology primarily, but there are other areas, of course, that a large subspecialized imaging enterprise can support decision making in all those different areas. And I think if you look at the ability for a health system to implement innovative care outside of imaging, a lot of it in many areas requires very specialized imaging support. In an academic center, it might be a little more taken for granted that because they already have that. Outside of that, though, it makes it very hard to innovate, whether it's pediatric cardiothoracic surgery, various neuro areas in neuroscience that I'm familiar with, different kinds of oncologic treatments, liver transplant program. You can't get very far. Stroke, you can't get very far without the very advanced imaging and very specialized doctors.
Okay, well, we have time probably for another 1 or 2 questions. Anyone like to raise their hand or type in a question? Okay. Well, so I have another question for Dr. Meltzer. So do you think we emphasize patient satisfaction too much? What if the patient's asking for some imaging tests that isn't really indicated? How do we manage that?
Yeah, I think that's a great question. And, I think there certainly was a time when patient satisfaction was a metric, and we didn't always have balancing metrics. And sometimes it could be overemphasized. Certainly, if a patient has back pain and goes to see orthopedic surgeon, and the surgeon says, gee, you seem fine and you should take these nonsteroidals and lay down for a week and see how you do, they may not be as satisfied as if an MRI was ordered, and that's been shown. But it may not be indicated, and it may not be best practice. So sometimes that's where we see exams that aren't indicated. And I think it's something where you try to explain to the patient what the value is. One place we've had a lot of discussions lately, both locally and nationally, is when a patient is unprofessional, berates a staff member, or treats them unprofessionally. We had one such incident a couple of years ago, and I felt that the staff really was deferred too much to that patient. It was an elective screening procedure, and if they had escalated to staff, we would have invited the patient to receive their care elsewhere rather than mistreat our staff. But I think sometimes we talk about everything for the patient. That's critical, but it needs to be balanced with other metrics considerations as well.
Okay, waiting for some hand raises, but I'll go ahead and ask another question to Dr. Breslau. So you had mentioned payments to providers is driving up much of the spending growth that's going on. Do you have any thoughts on ways that this might be curbed or reduced? I think you'd mentioned Medicare Advantage, but are there any other ways that they'll try to cut the cost down on the spending?
Yeah, and I appreciate your giving me credit for mentioning Medicare Advantage, but I didn't actually mention it. But yes, Medicare Advantage. There you go. That's my answer. No. I think that a lot of it are advancements of things we're already seeing, which is shifting risk over to providers, focusing on quality metrics. Payments are tied to patient safety, clinical effectiveness, care coordination, cost efficiency, and things that we saw for physician payments, changes in MACRA that will probably be a bigger delta over time, bigger dollars at risk based on performance. And that's, the things that are already in place, such as readmission penalties and some of the bundled payments. All those are ways. And those are much harder than what has already, as a health system, the consolidation has been primarily successful in terms of pricing power. And what they haven't yet done is really creating value, which is reducing the spend. And so CMS has kind of taken the ball and run with it and trying to force those changes anyway. But all health systems are going to have to figure out how to provide care with a fixed amount per patient and to use the hospital as little as possible.
Oh, it looks like we have a question here from Dr. Benson. You were unmuted. Oh, hold on. Oh, there we go. Oh, Dr. Benson?
Yeah, can you hear me?
Okay, there you are. Okay.
So I know like the more visible we are in the hospital as radiologists, the better, the more involved we can be, and going to things like tumor conferences and neural conferences and case conferences and such makes us more visible. I'm wondering if you've had any other strategies to kind of build a bigger presence in the hospital to kind of work towards gaining leadership positions and things like that.
Oh, sure. Okay. So first of all, we support a large number of conferences, and I actually had to look at it for an annual report. But in our part of Sutter, which is smaller than the whole health system, we sent at least one radiologist to 600 conferences last year. Then we support people getting into leadership roles. The current chief of staff at our largest hospital is one of our radiologists. And we're always very supportive of that when it can, when those people are interested in moving to that kind of a track. And all of the other thing that we do is all the radiologists that are involved in some kind of, or moving into some kind of leadership role, even at one care center, are paired up in a dyad partnership with a member of a person who's either a hospital executive or hospital director or something like that has kind of the same portfolio, and so they kind of work in a partnership, and that really facilitates stronger ties with the overall management of the health system.
Okay, yeah, I appreciate it. Thank you.
Carolyn, did you have any?
Yeah, I would agree.
Tremendous experience in this area.
Yeah, I try to have all of my leaders also be on key health system committees, and sometimes with dual departmental and system roles. So showing that, that connection and that value is just amplified. I can't possibly go to everything myself, and it is really important to have as many your leaders and both physicians and administrators embedded in different areas and value add projects.
Okay, so it's about time here. Our last slide is basically just a few things to point out before you go. Our next Power Hour webinar is scheduled for Wednesday, April 24th at 8 p.m. Eastern Standard Time. It's titled Creating a Culture for Innovation. Please respond to the confirmation email we're going to be sending to you, so it'll go straight to your calendar to be saved. We're also going to be sending you a post-webinar survey, so please take some time to fill the survey out to provide us with feedback on the webinar series. And a recorded version of this webinar will be posted and available that you can access through email. And with that, I'd like to thank our speakers, Dr. Meltzer and Dr. Breslau. And I'd also like to thank Dr. Rubin for co-moderating with me. And also thanks to Jen Pendo for organizing this webinar. Thanks, everyone.
Thank you.
Thank you.